Today it's my pleasure to introduce Dr. Neeraj Bajadiad, who is a friend and a mentor. He was one of my faculty when I was training at Maryland, and he is a leader in neurocritical care, so it's my pleasure to introduce him. Dr. Bajadia is the Chief of Neurocritical Care in the Program of Trauma, Professor and Executive Vice Chair in the Department of Neurology at the University of Maryland School of Medicine. He completed his neurology residency at Emory and training in neurocrit care and vascular neurology at Mass Gen. He has been an active member of SCCM since 2002 and is a fellow of the American College of Critical Care Medicine. He is also an active member in Neurocritical Care Society, having served twice on the board of directors, as well as the associate editor for Neurocrit Care. He is currently on the editorial board for Neurology, Translational Stroke, Journal of Neurotrauma, Therapeutic Hypothermia, and Temperature Management, and editor-in-chief of Neurocrit Care on Call. His research interests focused on targeted temperature management strategies, impact of nutrition and metabolism on recovery after subarachnoid hemorrhage, and the development of machine learning models to identify secondary injury after traumatic brain injury using continuous physiologic data. Funding sources of his work include the NIH, the DoD, and the Neurocrit Care Society. So it is my pleasure to introduce Neeraj. Thank you so much for joining us, and I'm looking forward to this talk.
Thank you, Evan and Shante, for coordinating this. I'm looking forward to the feedback I get from this group, and as I kind of go through some of what we've been working on here at Maryland. As Evan said, we're going to talk about kind of our machine learning approach to dysautonomia as a detection system for secondary brain injury. Disclosures for funding for really the work that we do is listed here, and really the most important part is the slide is the disclaimer that the views that I'll be expressing will be mine, not that of the DoD. So just as a general overview, what we'll get through the next 45 minutes or so is kind of the review of the incidence and impact of dysautonomia in critical care. And kind of introduce the concept of machine learning, especially how we think about it in patients with dysautonomia after brain injury, and kind of go through some of our approach that we're working on here and introduce the concept of multimodal AI, which is, I think, probably where we're going to need to be moving in our field, certainly not just in neuro, but I would imagine all of critical care, because we have the capability of doing things less invasively with our more advanced techniques that we have now. So just to take a step back, if we think about the autonomic nervous system, we know it's everywhere. And this illustration, I had to look a little bit hard to find this Netter picture. It's not as easy as it used to be to find Netter diagrams, but was able to find this that really does a nice job of shows what the autonomic nervous system does, and you almost question what it doesn't do when you look at that. It really does regulate all the involuntary physiologic processes, cardiopulmonary, as well as the essentially every organ system. It's really close, the close modulation of organs for physiologic homeostasis. The way I like to think of it is, in mathematical terms, it's what defines our standard deviation. It allows us to move within a range within each organ, and then as an organism as a whole. And then for our purposes today, really thinking about this, the CAN, the Central Autonomic Network, which is a neural network involving the brainstem, the hypothalamus, and the cortical centers. And when we think about that in a little bit more detail, in models of injury, I think there's two or three primary areas that we think about as intensivists. One is the hemodynamic control of the autonomic nervous system. Certainly the afferent limb, I think, about their baroreceptors making their way to the hypothalamus. And then the efferent limb is where you kind of get this vagal nucleus providing parasympathetic input to the heart. And then what I think mostly about in the ICU, what we see physiologically is sympathetic drive. And you think about the sympathetic input travels via the neurons and the intermediate lateral column of the T1 to T5, and kind of goes up through the medulla, paraventricular nucleus of the hypothalamus. And all those pathways are pretty intricately developed and disrupted pretty easily. And some would say almost it may be obviously considered part of our uh, physiologic response to injury itself. What we think less about, but I think is we're seeing more and more data emerging about this, is its role in the inflammatory pathway. And we see this, I would say, probably the most common expression of this that we're seeing is in all the work that we're seeing with the brain-gut axis. And parasympathetics modify inflammation through the cholinergic receptors and sympathetic control of macrophages, influencing the beta-2 receptors, and kind of encoding all the synthesis of the cytokines that we think about that play an important role in SIRS, which is throughout all our ICUs. So really, when we think about the control of the sympathetic, parasympathetic pathways, predominantly we're thinking from a hemodynamic perspective, but also from a inflammatory pathway. And in terms of its role in critical care, the dysfunction of the autonomic nervous system in critical care is nothing new. I think we know that it's a robust marker of severity and outcome. These are just a sampling of some of the papers that you could find in both general and neurocritical care populations that look at how the ANS plays a role after injury. You could almost think it's a maladaptive response to physiologic distress that leads to kind of prolonged sympathetic activation. And that's the imbalance that we are trying to always counterbalance. It's been shown to be a predictor of mortality and dynamic changes of the recovery state as well. And we need look at data across disease states, whether it be sepsis, trauma, primary neurologic injury, or even primary pulmonary injury. There's pretty consistent data that disruption to the autonomic nervous system is a marker of disease severity and marker of disease progression, both good and bad. So when we think about it in terms of the brain, how do I think about it in terms of ANS dysfunction in terms of the brain injured patient? So I think it's a measure of both primary and secondary brain injury, which in some sense is what makes it challenging to study. But I do think it's the first expression, clinical expression of brain injury that we see. If you're at the moment of injury itself, you'll see hemodynamic disruptions as well as just some basic core physiologic disruptions that really closely align with the severity of injury that you've observed. And by the way, we see this not only in severe brain injury, but we're doing studies where we're seeing this even within hours of a concussion, which I think we all recognize is more and more recognizable. But the changes that also occur within ANS expression and within ANS occur rapidly, and I think are reliable kind of upstream precursors of what will happen clinically, and that's what we think about with secondary brain injury. And that I think that's been the focus of where we've been trying to target our mathematical approaches. What I like about it and why I think why we want to study this is because I think it can be readily localized to specific areas of the brain injury, and we'll show some of the work on that. And it can be measured by modeling time frequency dependent changes to the heart rate. And what I really do like about the measurement piece is it's using techniques that we all use, and it doesn't have to be certainly in the neuro ICU or with invasive brain monitoring. So really, I think modeling dysfunction of the autonomic nervous system can really provide some clinical insight that's meaningful into mechanisms, which is what we're always trying to do at the bedside. So what I mean by localizing dysautonomia, and that has to do with this central autonomic network, which is this hierarchical structures of the brain within the telencephalic all the way down, sorry, to the spinal levels. And there's well delineated areas of the brain that have been localized over the years to deal with every aspect of autonomic dysfunction, including cardiac rhythms and the so-called cardunculus, which is the insula of the brain, all the way into temperature regulation and so on. Measurement, again, this is just an graphical description of how we can measure autonomic dysfunction with just the ECG or even the PPG waveform by looking at time frequency domains and looking at various features of heart rate variability. When we think about heart rate variability, we think about variability across time domains, frequency domains, as well as nonlinear dynamics. And this is just a table of kind of a common variables and their definitions, taken really from a European task force that I think published on these kind of standard definitions almost more than a decade ago. And when we look at heart rate variability, it can mean many different things, and all these features have been really well identified. The ones that I would kind of highlight here, the low frequency, high frequency, which is the ratio of the low frequency spectral power to the high frequency power. We think of that as the balance between sympathetic and parasympathetic in terms of the macro sense of what the autonomic nervous system is doing. So how do we do this at Maryland? We've been working on ways to collect this data, and certainly when I arrived in 2012, Dr. Peter Hugh, who's the head of our informatics group, PhD in the trauma program, had developed a vital sign data recorder or registry, where he was able to, as he showed me when I first arrived, capture all the waveforms as well as all the trends from any monitor in the ICUs. And at the time, he had the trauma ICUs connected as well as the trauma ER and the OR. And since then, we've expanded that to include the non-trauma ICUs, including the neuro ICU, as well as the helicopter systems, the helicopters that land patients. And so really, we have data from the moment of injury all the way through their ICU stay, and certainly in some of our trauma populations in their intermediate care setting or step-down settings as well. And Peter's own estimation is based on all the data that we're collecting, that we collect about 100 million data points per patient per day across about 200 beds. And so it's multiple petabytes of data, and he's developed a pretty remarkable system of redundancy, double redundancy. So we have 3 systems running in parallel so that we never lose data. That is, if one system goes down, the other systems, if both systems go down, then the third system is there. There have been times when all 3 systems go down. So in a sense, we don't have 100% data, but we're pretty close. The other way that the rationale behind developing this was actually an Air Force grant. The Air Force wanted a way to be able to visualize data in a fixed wing helicopter transport system or aircraft transport system from the far forward field to at that time, which was a launch tool. And they didn't want to they don't want to just look at the patient monitor, which is what we look at in the ICU. They wanted a broader view of what's happening with the patient and a little bit more graphically available. And with that, Peter developed what we call the CCAT viewer. And Evan probably remembers this, seeing this in the trauma ICUs. This is how I pre-round and how I would round in a neurotrauma ICU. And what you have here is a patient in our neurotrauma bed 6, where you have listed out their shock index running continuously. This is live. This would be live running. The heart rate running live, the blood pressure, SpO2, and then color-coded, including temperature, SpO2 as well. On the right-hand side, we would have scatter plots of blood pressure and heart rate, CPP and ICP. We've actually expanded this to include our newer metrics of neurodecline, need for blood, and other things that we're working on. And we could zoom in and out of this viewer, and now we also have the waveforms running live. So I can click on and I should have put that on here, a button down here that allows me to look at the actual waveforms, any waveform I want to look at. And as you see here, I'm on bed 6, but I could be looking at the entire unit in a snapshot and see that in bed 18, there's something going on as well. And if I needed to focus there, I could. And then when you move outward, you can actually do this across all the neurotrauma ICUs, but then across the entire house. And this is a view of the entire house. Anything that's red is a value that's out of range for a hemodynamic. All the pink ones are the ones that have ICP monitors in place, including their ICP number. So it kind of gives us this macro view. And the guys in the lab came up with this phrase "mom," which is a monitor of monitors. That's what they call it. And so mom is always watching and is always able to see what's going on. So that's been, a lot of the basis for what I'm going to talk about next, which is how we actually use this physiologic data. This is really designed originally as a tool, a visualization tool, that is now actually going through FDA approval for as a bedside monitor for the Air Force. So what do we do with all this physiologic data? So we can now store all this data alongside clinical, laboratory, and imaging platforms. And that's another layer of complexity, right? So the question is, can we use this data to actually identify things that may be happening in the near future, or identify what's happening with our patient now? And specific to our question in our group is, can we use this to identify those things that may lead to neurologic decline and poor outcome? So this is kind of the typical patient. We have all their labs running here alongside another platform of vitals and the exam. And we're trying to determine, is it the patient going to deteriorate, yes or no? And it's pretty straightforward, except when you realize that the interrelationship is not, right? These things are all related to each other. And this is just laboratory data. Imagine adding the clinical exam, imaging, and other physiologic parameters into it. So this is really introduces the idea of big data analysis, or AI, artificial intelligence. And that concept of AI in critical care has seen a rapid rise in the peer literature. If you look at this, I pulled this PubMed table graph, I guess last week on the 21st. And what you see in orange bars is the number of publications. If you just do a cross search between AI and neurocritical care, you see about 40 publications in 2024, and you see where we started in 2014. Critical care writ large, you could see it's just even 10x, almost 10x, more than 10x more, the number of publications that are coming out. Terminology can be confusing, though. I think what people mean by AI can mean many different things. And I think this graphic, I think, did a really nice job of describing AI as the kind of the global umbrella under which there can be different types of machine learning algorithms and deep learning algorithms. So it's important when you read these papers, what is it when there's, the title says AI, that catches your attention, but then you have to really understand what method are they talking about? And is it even AI, or is it something else that's just they're using the terminology AI for? I do think that, the idea of using AI, and I call it augmented intelligence in neurocritical care, is really, we're really well positioned to do that. If you think about it, everything we do in the ICU, it has a data attached to it that can be leveraged. And so when you think about big data in the ICU, we have all the patient information coming from Epic, as well as the billing diagnoses coming from Epic, the interventions from Epic, in our notes, whether it be in our pharmacy tabs and whatnot. We have routine laboratories, some of the newer laboratory tests that we're able to pull in, things that we are limited, but still can pull in imaging data. At least in our Epic, we're able to link directly into our platform for imaging now. It's kind of nice to have that. We think about natural language processing. We can actually leverage what we write in our notes as data, and especially when you look at it across multiple events and episodes. And then, of course, there's the monitors that we always think about and use at the bedside. Physiologic monitors. Ultrasound is another monitor that can be leveraged as AI if you look at the images as data. And so really, there's almost an endless stream of data streams that we're looking at. And it's hard for us to even recognize one, as humans, to recognize one, two, or three data streams put together. But if you put all these different streams together, it's really impossible for us to synthesize that in a meaningful way, in a data-driven way. I think that's certainly where we think of the art of science, art of medicine comes into play, is how we leverage all that information together. But it is changing how we think about research paradigms. And this was a great, actually great review in New England Journal of Medicine that came out recently. I would ask everyone to take a look at. Kind of gives you a good framework of how to think about where AI is leading us. We used to traditionally think of a statistical model as statisticians, clinicians, epidemiologists, any one of us sitting there with an important question and then pulling the data together, thinking about all the different factors that may be leading to a risk factor or intervention that may be worthwhile doing. There's some um, judgment put onto the data that we get, and that's kind of how we've done it traditionally. It's this statistical model, and the AI model, it almost gets flipped backwards, where the data tells you where the risk is, and it's not your own sense of what you think is high risk. So the data will pull out features for you that you may not have thought of, and you may not have had a scientific reason to think of. And it can do it in a much more facile way, a much faster way than we could with traditional epidemiological modeling. And you think about what this may lead to is a kind of hypothesis being almost irrelevant. And this is where I have trouble with AI and its utilization, was where we develop models that aren't hypothesis driven, but there is certainly that opportunity to do that with AI. You can really develop models that tell you what may be happening that have not really sound hypotheses around them. And so the explainability factor is a huge factor and a huge problem with AI models. So other areas that people have highlighted as concerns include, the ability to reproduce or generalize what we see, interpreting the data. And I struggle with this with our lab group from time and again, where our data scientists will come up with some great models, and then I ask to see what's in those models, and it's hard to interpret and hard to explain, and have a hard time really believing so-called ground truth in those. And AI doesn't actually deal with anything with equity and may actually, or access, and may make those things even more inequitable and access even more difficult, given how much it relies on high resolution data or data, how data intensive it is. So that's another concern that we have. And these are just some of the concerns. I'm sure we can discuss more in our discussion. So how we think about it in critical care, I think one way to think about AI is it can help provide clinical decision support with predictive models, both using supervised and unsupervised learning models. And as an example, we use CDS tools all the time, and these are examples taken from a neuro population where you have the ICH score, the crash prognostic score for TBI, the ISS score for trauma. These are prognostic scores that help provide clinical decision support to us as clinicians when we're seeing patients, if we know their ICH score is something or their ISS score reads to a certain number. Good example of this is a patient that we've had recently here at Shock Trauma, a 28-year-old who was found with a GCS of 5, anisocoric, and multiple penetrating wounds. After 1 hour and resuscitation, the GCS remained 5T. The CT scan, as you see there, if we put that into our crash calculator, you see the risk of 14-day mortality is about 9%, whereas unfavorable outcome is about 46%. But pretty broad range across both those numbers when you're thinking about what they really mean. What I'll tell you is that in the ICU, the mortality and unfavorable outcome, while they always matter, they don't matter in the next hour or 2 or 3. They certainly don't matter in the next 2 to 3 days. They matter in terms of the long-term trajectory where we're going, but it'd be nice to have some intermediate points in between that to really know where we're heading. And specifically in this case, the question I would have is, will there be any decline from raised ICP, hematoma expansion, seizures? Because that could really change that outcome to unfavorable to 55% versus 37%. That range could be really related to the secondary injury that they may have. And sticking to traumatic brain injury, and what we do know about TBI, in moderate TBI patients, there's a large data set from a National Trauma Data Bank published several years ago, where they found that 2/3 of the patients with a moderate TBI had a neurological decline requiring critical care interventions, which included some surgical interventions. The risk of poor outcome is related to the decline itself, as well as you would imagine, older age and polytrauma. So this really brings up the question that how do we know that TBI patient that is going to do well or not well? And I thought this was a very informative study coming out of the Canadian group where they actually asked this question: what determines neurologic prognosis and CDS, clinical decision support making, in patients with severe TBI? And reassuring to me as a neurologist, the exam still mattered to most Canadians, and the exam was important. But what was pretty close after that was the vital signs. And really, I was surprised by that because we wouldn't necessarily think in a neural population that the vital signs would matter. In fact, they seem to matter more than the neurologic specific signs. Now, this could be because most centers don't necessarily have all the invasive monitoring available to them. The electrophysiological data, this study was done several years ago, almost 12 years ago. So this would probably look different today, given the availability of EEG and electrophysiological tests is much greater than it used to be. But really, this kind of analysis made us think, well, can we provide some better way to give clinicians at the bedside a tool that they can utilize that's leverages what's available in all, which is, vital signs are available in all, physiologic data is available in all in a TBI population. And this was one of our first studies funded by the Air Force, called Rapid TBI, where we were trying to model the autonomic nervous system in combination with routine clinical assessments, because we see the value of the clinical assessments to reliably predict decline across a wide spectrum of TBI severity. And how do we do this? On the physiological side, we actually took just the first 60 minutes of data from the TRU, and it turned out to be about the first 45 minutes of data, because we wanted to capture data before the patient had any imaging or any laboratory results come back. We looked at the PPG and ECG waveform continuously. Our team was able to develop algorithms to remove artifact, which happens a lot in those first hour as patients are being jostled, moved around. But we're able to extract features from the waveforms that we did get, approximately about 180 plus time-dependent frequency nonlinear domain features. We were able to extract per waveform, per beat, and use that to see if we can identify physiologic patterns that may correspond to a secondary decline in a patient with TBI. What we found, and we published this a couple of years ago, was neurological decline happened pretty early, whether it be surgical or radiographic decline happened within, really most of it happened within the first 6 hours after presentation in this cohort of patients. And when we looked at our ability to assess that just with the clinical data that we were presented with at the bedside in the TRU, which is the GCS, the age, and blunter penetrating injury, our ability to predict early or late decline, and this is a time to event analysis, so at hour 2 or hour 48 or 45 was about 0.75, 0.8, which is actually not too bad if we just use the clinical data itself in a machine learning algorithm. But if we applied physiologic data, just the physiologic data, so this is just agnostic to the patient's age, their GCS, sex, or presentation, it actually outperformed the clinical data in ability to identify time to secondary decline. When we combined the two, it performed a little bit better, but not statistically different. What was important to me, though, again, going back to explainability, this model, which used combined physiologic clinical data, you see the clinical features highlighted here in the red asterisks. The GCS was still the most important. This is SHAP display, which displays the most important variables, the top variable being the most important in terms of model strength. The admission GCS was still the most important factor, which tells us, again, we need to anchor what we do, at least for our work, on the clinical pieces. Age played a significant role, as well as blunt mechanism. So this a lot of this mathematical computational work was done by Ximing, and Ximing, as and I were talking one day, and he said, I said, well, if there's a way to really, the GCS is only a partial accurate tool, even in TBI, for really assessing severity. I think if we had some of these other models like Apache or ISS that really tell us more physiologically what's happening, that would be more meaningful. But we don't get those data, at least the ISS, so at least 24 hours later. And he commented that he'd been working on a way to mathematically derive the ISS from the physiologic data. And I said, well, that would be interesting if you could do that. And certainly he was able to do that, as well as develop a mathematical model for GCS. And with that, we are able to actually apply that machine learning ISS score to the first 15 minutes of data to see if we could use that to predict mortality as accurate as if we had the ISS score 24 hours later. And what we found was that the machine learning TRIS, which is the trauma version of the ISS, and the TRIS performed identically the same. And of course, we were able to get the machine learning TRIS 24 hours, obtain that 24 hours in advance to when you would clinically. So this was, I thought, a pretty important proof of concept for us that we could potentially use this tool, something like this, to identify mortality, which is obviously an important thing to identify early on, and can help clinicians at the bedside. Now, this is all pilot data, even though this was done in about 1,000 patients. What I'll tell you is we need to do this in 10,000 or 100,000 patients or this is done in 29,000, but we would need tenfold more, if not more, to really say that this is a reliable tool. And we are working on trying to obtain larger data sets from other institutions or other sources to really try and validate some of these models. So what are we doing in terms of our next steps within that rapid TBI platform is to really provide long and short-term outcome relevance, which I haven't shown you any of that because we haven't really linked any of this acute analysis to long-term outcome. But we also wanted to try to link this early triage modeling to tracking secondary brain injury and enhance specificity. So some of the details I didn't share with you is that our models are really designed for sensitivity, but the specificity is not as great. And I think a lot of that has to do with the fact that we don't have neurosensors, that is, things that tell us more about the neurologic health. The ECG and PPG can infer through the autonomic signal detection what may be happening neurologically to the patient, but having a direct monitor like a pupillometer or even reduced montage EEG may be actually more meaningful. Certainly adding neuroimaging as a static measure would be great, as well as kind of routine and novel biomarkers into all this. So really thinking of this, again, as a multi-modal, multi-platform way to think about AI. And with that said, we actually were recently awarded a DARPA award to essentially develop an infrastructure for developing this. And this is a grant that I co-PI with Peter Hugh, Bill Teeter, Rosemary Kozar at Shock Trauma. And what we're doing in this study is actually taking those first few minutes to hours of arrival after a traumatic injury, first 5 minutes, 15 minutes, 60 minutes before they arrive to the Shock Trauma Center, and then out to 4 hours later with about 1,000 patients where we have just physiologic data, and then another 2,000 patients where we add in EPIC data, which is big data in of itself with all the different data streams there. And then within a subgroup of those patients, yes, of course, it will apply multiple different machine learning models to look at trying to predict who needs a life-saving intervention. Of course, my interest is in neurologic procedures, but writ large, our group is looking at a whole host of interventions that may be required, trying to predict who needs them early on in the so-called early triage setting. And but in a subgroup of these patients, another subgroup of these patients, we're going to actually add in physiologic monitors like pupillometry and near infrared, where we're applying near infrared to the forehead as well as to the deltoid. So we're going to have near infrared tissue monitoring, tissue oxygenation monitoring systemically, or as well as what we think is telling us about the brain as well. We've collected, we're about 400 or so patients into this analysis of the post-hospital patients. We have a cohort of about actually more than 1,000 patients now where we have the pre-hospital data on. So how are we going to use this data? This kind of goes beyond thinking of it as just clinical decision support. I think it really may help us identify subgroups of patients that actually can really we can target more effectively, so-called endophenotypes. And this is kind of an illustration. I think many of us in the ICU already know that you have patients who come in and they have an ICU stay and they can have a very different trajectory based on certainly their premorbid factors as well as their recovery pattern can be very different. And some of the folks, especially our younger folks and middle-aged folks, can have a pretty wide variety of trajectory back to near full recovery or or not. And where in our older population, we tend not to think of the full recovery as happening. But the idea would be if we can identify which one of these cohorts you may be, or where along this pathway you may be, or certainly what factors are going to contribute to this trajectory, would be really kind of a meaningful decision for us to have. And with brain, time is everything. So trying to do it sooner, the better. So, one of our fellows who's graduating, Ken, is going off. He's a Walter Reed fellow, is going back to Walter Reed after graduation. This was his fellow project where he wanted to really understand, can we identify who's in shock, who's coagulopathic, who has polytrauma before they arrive to the trauma center, that is in flight, before they get to us. Because as he said, that would really change our ability to deliver effective targeted therapies at the moment of impact before they get a brain scan or anything else that really tell a serum lactate level to tell us, yes, they are in shock. And some of our pilot data with 1,000 patients, which we're working on publishing, is showing that we're able to do a pretty good job of identifying those who are in shock or coagulopathic, not so much as those who have polytrauma, but our ability to just use basic clinical data, again, GCS age and mechanism of injury, plus physiologic data, derived ANS factors from the physiologic data, are able to tell us who's in shock, who's coagulopathic. And this is in a cohort of 1,000 trauma patients, of which about 500 were TBI. So this is kind of ongoing work. We're hoping to refine this now. We're in discussions with our helicopter services to whether or not they would want to use pupillometry in the field to help us identify some of these patients with greater resolution. Then, of course, the other way is once the patient gets to the ICU, can we identify ways to track disease progression? And this is an effort that's been funded by the Air Force through CDMRP mechanism, where we're trying to see, can we predict the next 2 hours by using all the continuous physiologic data as well as all the clinical information, radiographic results, not just the results, but also radiomics and laboratory data to predict the next 2 hours. And just a sample of what we're trying to do is, you can see here, this is us trying to predict the ICP out to 2 hours. And what you see in red is kind of overlay of the patient and our machine learning algorithm. And in the dotted lines, we're trying to see whether or not this accurately predicts what the patient's going to do. I think our prediction is reasonable at 5 minutes, as you would imagine. okay at 1 hour, at 2 hours, probably not so good. So this is still ongoing work, and this is work that was done without adding in epic data or radiographic data or laboratory data. This is just physiologic data. So our hope is that we're going to be able to refine this and try and develop what we call a continuous TSI, or trauma TBI severity index, that will not only allow us to track the progression of the patient, but also try and predict what may happen if you were to give hypertonic saline or hyperventilated patient with TBI and raise ICP, kind of give an idea of where the trajectory may be going. And this is built into this idea of which I won't get into great detail, the idea of developing a digital twin, which is, can we accrue enough data and enough knowledge through machine learning algorithms to identify where the next patient may be or may do based on where they've been and what interventions we've already done. So, certainly we're not going to get there with this initial effort. We're going to hopefully develop the foundations or lay the groundwork for developing something like that. But that's kind of what we're working on right now. But to shift gears for the last few minutes here to talk about where I think the ideal adaptation of AI analytical tools can occur in a TBI population, especially when you're looking at autonomic dysfunction, is sympathetic dysautonomia, or PSH, paroxysmal sympathetic hyperactivity. I think it's, like I said, the ideal adaptation of these tools, where we know in PSH there's this imbalance between sympathetic and parasympathetic drive. It's greatly reflected in the vital signs that we see: temperature, heart rate, blood pressure. It has a frequency, periodicity, and intensity that we can map. And there are, importantly, mechanistic treatments that can be beneficial, though if your institution's like mine, we kind of use them, but we don't really know how we're using them. We have an algorithm that we supposedly utilize and stick with, but it's really it's a best intended algorithm that doesn't really have a lot of basis in foundational basis for its use. So Jamie Podell, who's in our group, is working with Karen Chen at University of Maryland Baltimore campus with her AI group, and trying to develop an automated PSH index that really takes those vital signs and tries to automate not only the intensity, but the frequency, the intermittent nature of it, and trying to develop a way to identify that we can do this more consistently and reliably, so that if we are going to actually intervene, we know what we're intervening on and how we're intervening on them. And so they're using some pretty cool techniques, including anomaly detection, to identify when a storming episode may happen, because as we've all seen, they can happen within a second or a minute or two, and some can last an hour or 3 hours. So trying to identify all those different features is what they've been working on. And I think what's most important to what Jamie's doing and is trying to link all this physiologic monitoring to imaging. And this is an example of a storming case versus a non-storming case. And visually, you can tell that there's something going on with this patient in terms of the heart rate and blood pressure versus not in this patient. And you can see that there's a difference in the pattern of contusion that may be there. And what Jamie is doing is actually looking at all the MRIs that we have, and she's published on this a little bit already, more publications in the way, where we're using known masks of connection networks within brain MRI sequences, and mapping that or co-registering that with our TBI patients and identifying patterns of injury that are more prevalent in different types and subtypes of storming, and really trying to create that link between the physiologic monitoring and structural injury that we see in our TBI patients. She's hoping to, she's submitting her K next week, so we're hoping that she'll get funded to really work on this in great detail over the next several years, and really enhance our understanding of storming. I think through her work, I think we'll also be able to identify more of what we think of when we think of autonomic dysfunction and how that may track with disease progression beyond PSH. because I think it will give us so important lessons on how to think of the data that we're seeing at the bedside. So really, I think when we kind of think about what we're trying to do within our group is we're trying to model dysautonomia because we think it's a robust marker of injury severity and early sign of disease progression. It provides, I think, insight into structural disease as well as what may be contributing to multi-organ injury in our patient population. There's a lot of key next steps, which is identifying groups and subgroups, some of what Jamie's already doing with the PSH group, in incorporating the multi-morbidity, which I did not get into, which has to do with pulling in data streams from other monitors as well as other laboratory data having to do with cardiopulmonary function, renal function, and then really ideally trying to pull that into a real-time data stream, which I think is really aspirational. I think really steps A and B are where we're at right now. We're trying to really identify groups that are meaningful to study, as well as how to think about incorporating morbidity. But this is kind of where we're, the concept of multimodal AI in neurocritical care, which is pulling in the patient assessment, vital sign monitoring, imaging, neurophysiology, their demographics, lab tests into kind of a real-time model that then can give you better information about somebody who may have storming, seizures, maybe early signs of sepsis, and what interventions may be worthwhile entertaining for the clinician at the bedside. So, using these models to develop a tool to support the decision-making for the clinician at the bedside. And ideally, this is done in a closed loop format so that each patient contributes to the population of patients that we have and contributes to the overall knowledge of what we're doing in developing kind of this automated progression of injury in TBI. So with that, I'll stop and certainly acknowledge a lot of folks in our lab that have been doing all this work, some of which you saw their pictures for, but as well as our collaborators, in trauma, neurosurgery, EPI, as UMBC, and our sponsors and funders as well.
Niraj,
Thank you.
thank you so much. That was amazing and really, really interesting. It's amazing to see how far everything's come. I remember when the cat viewer was just getting rolled out when I was there. How do you use this day to day? As you said, you use the cat viewer on rounds, but how do you use more of these AI models on rounds and in direct patient care, or is this more still in the laboratory at this point?
Yeah, so the CCAT viewer I use every day, much to the annoyance of the fellows, because I can sit in my office and say, "Hey, what's going on in room 4?" Because it looks like the blood pressure is dipping, and so I think that I would say, and I can pull that up. In fact, let me see if I can pull it up while I'm talking to you. But it allows us to. I think it's really become a powerful clinical safety tool. I would say I don't know that how much I would say I make clinical decisions just based on the CCAT viewer, but it kind of is a good screening tool for me, if you will, in terms of what we're looking at. The other models that I showed, like the neurodecline model, we actually came up with a neurodecline metric, and our trauma colleagues have come up with a brain transfusion index metric. We're talking about how to display that, but visualization, as I'm learning, is a whole another science. And we spent literally 6 months on talking about how to display something that was meaningful. The statisticians, epidemiologists had one way of thinking about it, clinicians had another way. And honestly, we have not come to a decision on how to do that. And I don't know if it's ready for prime time, if you will.
Got it. I'd like to open up the floor if there are questions. David?
Hello, Niraj. Thank you for an excellent talk. It was, really thought-provoking. One of the challenges we all have is building AI into workflows, and one of the underlying problems with that, of course, is having a good data infrastructure and data cleaning. So I'd like you to, if you could, just, bare your soul a little bit. Tell us about the pain points you've experienced, because I think it's just important for people to understand how difficult it is along this journey to achieve something which is reliable, valid, and then is actually accepted by people in the workflow.
No, absolutely. I think, and that pain never ends. And I think it is continual pressure. So, our informatics group, Peter Hugh, who leads it up, has been doing this for about 30 years. So I walked into this 20 years in. And so, but listening to him about the initial, literally going room to room and figuring out where the cables are and all that, we've gotten past that piece of it. But the pain points we continuously have is, I was rounding last week and I noticed on the CCAT viewer that the ICP monitor wasn't working. I wasn't getting the ICP data. So I called down to the lab. I said, hey, I'm not seeing the ICP. And they realized that there was a upgrade that was done 2 weeks earlier, and we had not been apprised of it, and we lost some of that data. So we had to go kind of develop a patch to get that data back together. The clinical engineering group, which I think we have a really great clinical engineering group here. They're clinical, they're not research, right? So the discussion between the clinical team and the research team is constantly happening so that we are maintaining the clinical standards, but also capturing the data for research reasons. We are in the process of going throughout all 12 hospitals, brand new monitors at the bedside. If you can imagine, Dr. Rich, what that's going to be like. So that discussion has been a multi-year discussion. It's coming to a head now, and the most difficult parts of that discussion has been the IT parts. How is this data going to live? Where is it going to live? How is it going to stream into Epic? Are we ready for Bluetooth for all this stuff? Are we ready for what's the next wave of things, the cloud? How much of this should live on the cloud? So much of this is just being figured out how to be regulated. And so we want to be on the right side of that as well. So it's a constant discussion.
Neha.
Thank you.
Neeraj, thank you so much for an excellent talk, as always, very insightful and thoughtful. You also showed a lot of pre-hospital work, and you're getting this data from the back of life flights and helicopters and ambulances. How have you managed to harmonize that data? Because a lot of the systems that EMS crews and flight crews are capturing are in older generation CAD systems. How did you manage to harmonize some of this waveform data with what you have inpatient?
So in a sense, we're not capturing it from all. We're capturing it from the state-run air ambulance system, MSTP, and we basically bought their systems for them, and we installed them. And we said, this is what, because in the end, they're agnostic. They just want to be able to have reliable front side data. The backside where we're interested, we bought the interfaces for them. There's 8 helicopters, so we purchased the 8 licenses. So we kind of hacked it. It's much harder, I think. I know what you're getting at. I think that's a much harder task. Yeah.
Thank you.
Yeah.
Dr. Bajaj, I thank you so much for your great talk, interesting talk. I'm one of the neurointensivists at Mount Sinai. And I remember when I saw a lot about a TBI patient when I was a fellow, it's just a really interesting for patients with like a really high first TBI, like a motor vehicle accident all the time, like not all the time, but many patients have a really tachycardia, even though they didn't look like agitated or anything like that. And then the first few days, and really hard to control sometimes with even increased sedation. But, but then we don't see such a thing with like older folks have a TBI more like for traumatic subdural hematoma with just like a fall, it's not a really high impact like a TBI. We don't see such a sign. So I wonder, it's a very interesting vital signs, like has maybe some role in predicting patient outcome. But then I wonder if we look at the depending on different brain pathology. And also my second question is, Actually, not having like a proper physiological response to TBI can be a sign of the malfunctioning brain, like rather than the abnormal vital signs reflecting a severity of a brain injury.
Yeah, so I'll take that latter part first, because trying to identify when the signal is a sign of recovery versus a sign of secondary injury, that's extremely, I would say at this stage, difficult for us to understand. I think we have to still anchor ourselves in the epidemiology of the disease. So on day 1, it's probably not a sign of recovery. On day 18 or day 20, it may be a sign of recovery, right? And so I think that's where these mathematical models cannot be agnostic to the reality that we're seeing in front of us. I think the best we can say is that they can support your decision making. They shouldn't drive your decision making. In terms of other diseases, we're involved with colleagues down the way from you guys at Columbia and looking at hydrocephalus and SAH as well as TBI patients. We are also interested in, what I didn't show is trying to identify patients who are going to have reperfusion edema after thrombectomy with the same principles involved. And most recently, we've started to think about how we can look at the same concepts in ICH. So I think some of these things are more broadly applicable. I showed this specific example of what we've done in TBI, and they're pretty specific, but we are thinking about how to generalize this. The other population that I think is somewhat unique to us is we have a really large SCI population, spinal cord injury population, and we have about 1,000 patients worth of data that we haven't even touched yet, that has well-described MRI scans by Bijan Arabi and others, and all the physiologic data. So waiting for a fellow or junior faculty wants to take that on.
Neeraj, you guys certainly do have a lot of spinal cord injuries, I remember. We have 2 more questions we can try to get to. Pranay, if you want to go quickly, and then we can get Cappy before we run out of time.
Sure. Hello. I am like a medical intensivist, so I freely admit that I have very little trauma experience unless a patient falls out of bed. But one of the issues that we face, aside from the infrastructure in deploying and operationalizing some of our AI tools, is designing like a useful intervention and then getting like good adoption and like program monitoring. So like let's say even from the ambulance or the helicopter, as it were, if someone is at a high risk of deteriorating the next day, like how do you design like the workflow around that? Like because presumably all of them will go to a trauma bay and need to go to an ICU, right? So and then once that is done, how do you monitor those things, get feedback, and adapt from there?
Yeah, so I think from a research perspective, that's honestly why I've stayed away from subarachnoid hemorrhage, because I don't know if Nao or Cappy can define what vasospasm is. I certainly can't. And so trying to define an undefinable, it makes it hard to develop an intervention and hard to get buy-in. So I think you're absolutely right. You have to find something that's truly definable. I'll tell you, the real story of how we got the physiologic monitoring into the neuro ICU. It was one of the things I did not ask for when I came here, but I certainly said we need this, and we designed a bed alarm project. So we said that with this system that we have in place, we actually can also look at alarms, and we devised this study that we basically reduced bed alarms by about 70%. And we said, and we showed to the hospital, like, look, if we can do this, we all recognize the importance of that. Will you fund us to start our infrastructure? And that's how we got us funded. So we found something that was a very common thing that this data can do. It's not mechanistic, it's not physiologic, but it's practical, right? And it's important. And reducing bed alarms by 70% was huge. And so that's how we got funded to really expand the program beyond just the trauma units. Cappy?
Hey, Neeraj, thanks for the great talk. I imagine as this is kind of developing in sort of a research context in terms of predicting secondary brain injury, and while I think it's relatively straightforward at how you kind of, have streams of physiologic data coming in and recording it. One of the practical, I guess, challenges is how do you make sure that you're getting, when you want to get neurologic assessment data, which is not as straightforward to collect, it seems, how, can you go about making sure that the neurologic exam assessments are sort of, reliable and as comprehensive as you want to correlate with the physiologic data. So for example, I mean, I guess you could try to, do text analysis of notes, but, it's only as good as the note describes the exam. And if you're relying on a nurse assessment on an hourly basis, kind of the same problem. So I wonder kind of how might you approach getting reliable streaming neurologic assessment?
Yeah, that's a real problem. I think that's why in the TBI world, it's a little bit easier. Same issues, but a little bit easier because the GCS is, we all know that there's not great reliability, but it's probably greater than that of a neuro exam, written neuro exam. So we've relied on the GCS scoring by our nurses, and we, in that first rapid TBI study, we painstakingly looked at every hour over 1,000 patients worth of data for 2 days. Imagine how many flow sheets our team had to look at to make sure that the neuro exam was done off sedation, not paralyzed, all those things. So we went to that level of resolution. To scale that up is not practical. And so I know others who are working on this, like Charlene Ong at BMC. She and I had a long discussion about this a couple of weeks ago. She's also trying to figure out a way to have a reliable neuro assessment, for example, in the stroke population. How do you know that the exam is consistent day 1 to day 2 between second year resident, third year resident attending, especially if we're using large language models. I think the best we have right now, and we're working on this and we're thinking about it. We haven't even done anything with it yet, but we're trying to restructure our notes so that they could be more discoverable and more objective, even for the exam. And so that's going to be one possible solution to this.
I know it may sound like science fiction right now, but I wonder if there may be also sort of continuous video with analysis of patient, by AI itself that doesn't even rely on a human being.
That's not science fiction, Cappy. I've seen it. I've seen some of our colleagues. I think it was at Gainesville. They have the immersive ICU where they have the video on the patient and just the facial expression of the patient. They're using that as a quantification for delirium, pain, other things, and it's amazing. I think that may be.
We have our paper in preprint right now with Pose AI. We're essentially trying to quantify the neurological examination using these Pose AI models. Out of the box models, the model will need training, but we did this with video data on video EEG machines, essentially an epilepsy monitoring unit in NSICU. So it's coming.
Yeah, no, I think that's probably going to be certainly a good way to do this.
Thank you so much.
Yeah.
Thank you, Nick.
I think there's another meeting, right, Evan? But
yeah, thank you, Neeraj. It was great to see you.
Thanks, guys.
thanks,
Yeah, it's great
Neeraj.
seeing everybody.
Send my
Thank
best
you.
to everyone.
I will. Bye.
All right.